Okay, so we're recording now, so whatever you say will be heard. These lectures are up, I put up on the website Retina University. I'm trying to populate it with lectures and some teaching material. There's this, I've combined them into one lecture this year just for speed, because we want to do an introductory lecture at the beginning of each year. So this combines the anatomy and the diagnostic testing, and I trimmed them a little bit. There's also quizzes up on the website, which I'd like you to look at, because that way you can remember them better. And next year, we'll not do a lecture, we'll just go over those quizzes. And it just asks questions. These are mostly from your chapter, although I do add a little bit to them to make them more interesting. Here we go. So the structures we're going to cover in the anatomy, the structures in the textbook are vitreous, neurosensory retina, RP, Bruch's membrane, choroid, and sclera, kind of going front to back. I took out the vitreous for this lecture just to make it shorter, and also the sclera. There's all these goofy eponyms in the vitreous you have to learn. You just memorize those. When you look at the retina, we divide it regionally when you're looking straight at it into different sections. So the macula is the center 5.5 millimeters of the retina. A lot of people, one way to describe it to patients is it's about the size of a nickel. Some people can relate to that. Anatomically, it's 2 or more ganglion cells thick, and that's something you have to remember. You'll be asked that. Half of all the ganglion cells in your retina are in your macula, so that's why one of the reasons your macula has such high resolution is it's mostly ganglion cells more than photoreceptors, a little bit photoreceptors. The near periphery we don't talk about ever is a 1.5 millimeter ring outside the macula, and the equatorial retina we talk about a lot. And that's everything between the near periphery and the peripheral retina. Oh, you guys have to mute yourself now because it's coming through. Unless you have a question. Please feel free to ask questions. That's fine. Although this isn't really a question. Not a lot to question here. The equatorial retina is where you'll find equatorial drusen. It's also a weird dead spot where people often miss things on the exam. Because what will happen is you'll look at the macula with your 90 or 78 diopter lens, and then you'll put your headset on and you'll miss things in the near periphery. So you have to almost make an effort to look there. I'm sorry, in the equator. And then the peripheral retina is the posterior border of the vitreous base to the aura. And then when you slice a macula in half, we also have an anatomy. So that's when you're looking straight at it. We look at the macula, near periphery, equator. And then when you slice it, this is the anatomy of the macula. So the perifovea is the thickest part of the macula, which is over here, starting from the outside in. Again, we don't really talk about that ever. The parafovea is right between the parafovea and the fovea where things flatten out. The fovea we talk about all the time in the middle. You can't see my mouse here. I'm pointing with my mouse, but I don't see it. The parafovea. Oh, you can? Oh, good. Okay. The fovea is where the dip starts. So from where the retina flattens to where it starts to dip is the fovea. It's important to remember the fovea has only cones. You'll be asked that. That's absolutely a question that comes up on boards all the time. It's also got a very high density. Yep. Yes.
I don't know if this is important at all. Probably not clinically and probably not even testing wise, but the BCSE does say that the parafovea is the thickest portion of the retina. Not
the para. Okay, that probably is. Okay, so the parafovea is the parafovea is the thickest right here. Okay, right here. And then the perifovea, you're right, the perifovea is where it starts to slope up, thickest part, and then slope down. Yeah, thank you. The fovea is where it starts to dip, and that's only cones. It has a very high density of cones, 140,000 cones per millimeter squared. That's why, in the whole retina, when we do retina, what we try to save is the fovea. We'll do all sorts of horrible things to the retina in order to save the fovea. The foveola is the little dip here. It's smaller than the foveal avascular zone. And then the umbo is where the very shallowest part of the retina, the very thinnest part of the retina is in the middle. And that's when you get your central measurement or your central point thickness is right at the umbo. And when you look at somebody young and you get that light reflex, that's the umbo. Again, if you look at the retina anatomically, these are the slices in a histopathology slide, and you go the layers of the retina. There's 10, I think. Internal limiting membranes, this little membrane in the surface is about 10 microns thick. and then you get your nerve fiber layer, and you sort of alternate fiber, nucleus, fiber, nucleus, fiber, nucleus. So you get your nerve fiber layer, ganglion cells, inner plexiform, inner plexiform, internuclear, outer plexiform, outer nuclear here. And the outer nuclear is your photoreceptor nuclei. And then you get your rods and cones out here, which on the OCT do segment into a couple different layers. Then you have your RPE and your choriocapillaris. The retina is extremely organized. It's remarkable. It's remarkable when you look at the eye that you're capable of making transparent tissues. But all this is transparent. It's all optimized to transmit light because the receptors are on the back. It's not true of all species. I think reptiles have their receptors on the front, but we have our receptors on the back. Some important difference between cones and rods. Cones are for highlight levels, so they're also for color vision. You know that's easy. Cones and color begin with a C. They have a high spatial, they have high spatial acuity. Again, your fovea's got a very high density of cones. Even though the fovea is only cones, there are a lot of cones outside the fovea. And this is one of those interesting trick questions you could get. And then when you look at the fovea, there's a very high photoreceptor ganglion cell. There's a lot of ganglion cells in the center of the macula, and there's a one-to-one synapse between midget bipolar cells. Midget bipolar cells synapse the photoreceptors to your ganglion cells in a one-to-one method. Whereas in the peripheral retina, it can be many more receptors per ganglion cell. And you have 6 million cones. So in a way, when you look at the 120 million rods and 6 million cones, we are more optimized for night. And I think that's probably a survival advantage to be able to see things at night, even though we spend all of our time in the day. Rods are scotopic vision, very low light level, so they can detect one photon. It's remarkable the range of, there's still not a device, I think, that can mimic our eyes for range of bright and dark that we can adapt to. Rods are just black and white, so if you let yourself dark adapt, 30 minutes or so in the dark, you don't see colors. And again, since there's no cones in the fovea, the rods are hot, densest 20 degrees from fixation. There's 160,000 rods per millimeter squared in the macula area. And again, there's low spatial acuity. You can have up to 100 rods to one bipolar cells. And the receptive fields can, I believe, in the periphery be even thousands of rods to one ganglion cell. And there's 120 million rods. So that's rods and cones. One thing interesting when you look at the night sky, you may or may not know this or experienced, if you look at it straight at a very dim star, it disappears. But when you look off to the side a little bit, you can see it, and that's because of where your rods are. Your rods are higher density right off center. Some diseases where you lose rods and cones, or this is a patient with a dystrophy. If you look at the OCT, you can see your outer nuclear cells kind of disappearing over here, and your photoreceptors definitely going. And then when you look at the autofluorescence, there's a bright area where the photoreceptors are not there or sick. And this is MUDES. This is another photoreceptor disease. We'll definitely see this in conference. I haven't seen one lately. I think they're related to flu, and they come up in flu season, but that's another story. And this is an outer retinal disease. This is incorrect in the other lecture on the website, but this is correct here. The first order retinal neurons, the receptors are not considered retinal neurons. So your first order neurons are your bipolar cells. Your bipolar, horizontal, and amacrine cells, all the cells in the middle retina. And I don't think this detail is so important as to what they do, if you just kind of know what they are. And there's not a lot of diseases of the middle retina, but this drill is a recently described disorder where there's disorganized retinal inner layers drill. So this is a patient of mine who had a branch retinal vein occlusion with severe edema. You see the fovea is just totally split there. We actually got rid of the swelling. Excuse me, the ganglion cell layers are in pretty good shape. So you got a good nerve fiber layer here. So it's not the ganglion cells, in the nerve fiber layer. The outer retina, once you've seen enough retinas, that outer retina is probably about a 2200 outer retina, or maybe even a 2100 outer retina. You can see some of the outer lines. and the patient still only saw 3/200. So I think this is an example, when you can see the architecture of the inner retina is totally shot. So this is I think, a good example where those first order neurons are damaged and the person lost vision from that. It's remarkable how resilient the middle retina is. That's pretty uncommon. And then the ganglion cells are your second order neurons. So the axons project to the optic nerve, the optic chiasm, and the optic tract. The ganglion cells are the only neurons that actually fire action potentials. The rest of your retina does these graded potentials. So the rest of your retina is analog, actually. It's a remarkable system where it can tune up and tune down based on signal. And then at some point they fire action, they transmits it to the ganglion cells and they fire action potentials. There are ganglion cells that are photosensitive. This is new since I was in training, but this was on our board review. We do the recertification, and that was a question on our boards, was, are ganglion cells photosensitive? And they can be. And they have to do with the circadian rhythm, although it's not common. There's 1 million ganglion cells compared to 125 million photoreceptors. So your retina is really more like brain tissue. It does a lot of processing. Your retina does 1,000,000 to 1 processing of the image. And in your fovea, there's a ganglion cell for every 5 photoreceptors. And in your periphery, there's a ganglion cell for thousands of photoreceptors. And then ganglion cells are more, the macula has 2 or more ganglion cells by definition. And that's why when you get a central artery occlusion, you see retinal whitening in the center of the macula, but not in the periphery, because you just don't have that many ganglion cells in the periphery, and not in the fovea, because you don't have ganglion cells in the fovea. And this person had a cilioretinal artery. So the ganglion cells kind of define where you see retinal whitening in the central artery occlusion. Onto the retinal capillaries. There's the radial peripapillary network. I think is one of the more interesting capillary networks. Mostly because it gives you an idea where we see cotton wool spots. When you see someone with cotton wool spots, they're always kind of at the edge of this capillary network, or most always. Sometimes you get a stray one. And that's because this capillary network is your least robust capillary network in your eye. They're very long. The capillaries tend to be long and parallel, and they don't anastomose very commonly. And they're present in proportion to the nerve fiber layers. So where the nerve fiber layer is thick is where this capillary network is. And they can infarct when the circulation's bad and you get the spots. And then when you get into the center of the macula, you have 2 capillary plexuses, which each divide into 2 networks, so you end up with 4 capillary plexuses. Your superficial capillary plexus straddles the ganglion cells. So you have some capillaries here and some down here. You can see they kind of connect to here. That sort of spans 2 different capillary plexuses. And then your deep capillary plexus straddles the internuclear layer here. And your oxygen delivery to your body is mostly driven by mitochondria, because mitochondria use 95% of your oxygen. And the retinal neurons here they're actually are pretty much ganglion. They're pretty much mitochondria all along the axons, dendrites, and the cell body. So they're all throughout here. That's your inner superficial and deep capillary. And then this shows a disease called PAM, paracentral acute middle maculopathy, where you see the retinal whitening. There's some retinal whitening here, but you're also getting this retinal whitening in the middle of the retina, and that has to do with the capillary plexus as being more your deep capillary plexus losing circulation. So as opposed to that central artery occlusion where the retina was very white and the vessels were partly obscured, here you can see the retina is kind of grayish. So most of the edema in this case is actually not in the superficial capillaries, but in the deep capillaries. And then the retinal pigment epithelium. So this is going down. So the retinal pigment epithelium is a monolayer that absorbs light. It's important for that, but there's about 7 million RPE cells in your eye. So just about as many as there are cones, not just for memorizing. And they, 1 RPE cells phagocytizes billions of outer segments. I think it's 50 billion outer segments over the life of a person. So they do an enormous amount of work cleaning up your outer retina. Also, they form the blood-retinal barrier, and that's something you absolutely have to remember. The tight junctions between the RPE cells form the blood retinal barrier between the choriocapillaris and the retina. Not in the retina. In the retina, the blood retinal barrier is at the capillary endothelium, but in the RPE and the choroid, the blood retinal barrier is the RPE tight junctions. It's not Bruch's membrane, it's not anything else, it's the tight junctions between the RPE cells. And the RPE cells also maintain the subretinal space. They have a pump that pumps fluid out. And they unfortunately heal and form scar tissue. So that's why when you see someone with a scar from macular degeneration, it's the RPE cells usually that cause the scarring. The one thing that's not yet in common nomenclature is when you look at an RPE cells, the mitochondria segment to the back of the RPE cells, and then the phagosomes, which are what eat all your buildup from all the billions and billions of outer segments the RPE cells are trying to digest, are on the superficial layer. And there's some recent papers suggesting that those are the bands that we see on OCT scan, the two bright bands. When we look at the RPE cells, there's two bright bands. There's an outer band and an inner band. And it's probably the phagosomes, but for textbook purposes, it's actually the interdigitation zone. And we'll hit that in a couple minutes. So this is a macular degeneration where you get the RPE cells just get overwhelmed. For whatever reason, they can't keep digesting all the garbage they have to deal with during their lifetime, and they build up the drusen. So these are drusen, which are accumulations of lipofuscin and undigested products in your RPE cells. And then Bruch's membrane, lastly, is the membrane at the back of the RPE. It's between the RPE and the choriocapillaris, and this is a high resolution. I don't think this is electron, I think this is light. So you can see Bruch's membrane with light microscopy. And you can see Bruch's membrane on OCT scans when there's a PED. We'll show you that. Bruch's membrane has 5 layers. There's the basement membrane of the RPE, then there's a collagenous zone, elastic layer, collagenous zone, and the basement membrane of the choriocapillaris. And those all form Bruch's membrane. I always remember this because there's a vowel in the middle of Bruch's, which is a U, and there's a vowel in elastic. So if you look at like 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, that's the way I remember the elastic layer is the one that's in the middle. There you go. And this is a disease called angioid streaks, where there's calcification of Bruch's membrane and it cracks in sort of a round way. And the physics of the eye predict where the cracks form because the eye's tethered with the optic nerve. But there's a crack in Bruch's membrane. And what happens is people develop neovascular membranes. And then the choroid is where you have very, very high blood flow. The choroid nourishes your photoreceptors, which use an enormous amount of oxygen. And also, they kind of cool the eye. They have higher blood flow than you need just to nourish the photoreceptors. So they probably also do other things. There's a choriocapillaris is a single layer. At anastomosis, it's fenestrated. They're large lumen, and they have a very high oxygen tension. They leak. So the choriocapillaris is supposed to leak, and whereas the retinal cells are not supposed to leak. And by leak, I mean, I guess, leak fluorescein. They're leakier than retinal vessels. And this is an example of someone with central serous retinopathy, where there's an area here that's a little bit sick. You can see on the autofluorescence, and then on the ICG at about 5 minutes to 10 minutes, you can see these areas where the choriocapillaris is leaking more than it's supposed to. So this is kind of appropriate leakage, and this is inappropriate leakage. The choroidal stroma is pigmented. You can get melanomas and nevi in the choroid. There's 2 layers, which now that we have OCT, we do look at these. Haller's layers has the big vessels, and Sattler's layer is smaller vessels, medium size. So that's anatomy. That's pretty good. So I kind of wanted to cover anatomy and diagnostic, so I put these both together. So in the diagnostic, we talk a lot about ophthalmoscopy, but I'm not going to talk about that here because I don't think it's quite as interesting. You'll just have to learn that from the book. The lenses and, upside down and real images and all that. So first thing I want to talk about for imaging is autofluorescence. We show a lot of autofluorescence images and they can be a little confusing. There's a number of things in your body that autofluoresce, including things in the anterior segment. So your cornea and your lens autofluoresce. If you have someone with a cataract, even if it's a medium to thick cataract, you'll find it's very hard to get a fluorescein and it's very hard to get an autofluorescence image. And that's because of all the autofluorescence in the lens that messes it up. And then the macula does have some autofluorescence in it, but hardly any. And the RPE cells are your main source of autofluorescence. And then there are pathological things that autofluoresce, mostly the optic nerve drusen we use autofluorescence for. So if you're not sure, sometimes you look at this eye, it looks fine, you get an autofluorescence and you see optic nerve drusen. It's a nice test to confirm that. And then some subretinal deposits will autofluoresce in certain situations. The outer retinal segments, if they deposit in the subretinal space. The physics of fluorescence, just a brief refresher from your physics, is there's sort of these three different things. There's luminescence, where things generate light. So the sun generates light. If you have a radioactive watch, which I used to have, I put it away. It's an old one, generate light, and so does a light bulb. So luminescence is when you're emitting light. Fluorescence and phosphorescence are when you're re-emitting light. So light's hitting you, you're not generating it, and then you absorb the energy, and then your atoms get all excited, and then they shoot off light at a slightly lower energy or longer wavelength. And then phosphorescence is when you re-emit light, but there's a delay. So phosphorescence can be like a glow-in-the-dark thing. The reason I say this is just so you know fluorescence. And when we talk about fluorescence, when you do indocyanine green angiograms, that's still fluorescence. It's all fluorescence. People use the word cyanescence even in journals, and it's not, as far as I know, it's not yet an actual word, because really the indocyanine green fluoresces, even though it's not called fluorescein. In fundus autofluorescence, this comes from lipofuscin. So what happens is your damaged retinoids from photoreceptors build up from shed outer segments, and sometimes the RPE can ingest them, but then it can't get rid of them because they're not something it can quite digest. And the phagosomes I showed you in that other picture form lipofuscin. So lipofuscin is this, it's not exactly, it's just a bunch of stuff. And it contains A2E. It's not a single molecule. Lipofuscin is just sort of leftover stuff in the cells. And A2E is 2 molecules of vitamin A aldehyde and 1 molecule of ethanolamide. And since your RPE cells phagosize billions of outer segments, by the time you get older, up to 25% of their volume can be just lipofuscin. So they end up being a lot of lipofuscin, a little bit less melanin. And the lipofuscin is what autofluoresces. And when you hit it with a low wavelength, it re-emits. Dead RPE cells don't autofluoresce. So there's a couple of causes of hyperautofluorescence. So the two main causes of hyperautofluorescence are increased signal. So this is lipofuscin in the RPE. This is a patient with Stargardt's disease. So they've got all this buildup of lipofuscin, and you're seeing these bright areas which are hyperautofluorescent. The other one, which is a little confusing, is you can get window defects in the outer retina. So the outer retina absorbs fluorescence because of all the chromophores. If you think about it, your outer retina, your photoreceptors are engineered to absorb light. That's what they do for a living. And so they also absorb, as much as they absorb light coming at them, they absorb the light you're trying to see in your autofluorescence image. If your outer retina is missing or damaged and the chromophores aren't there, the rhodopsin derivatives of the chromophores, then you see more of the underlying autofluorescence. So this is someone with plaquenil toxicity. It's very subtle, but you can see a bright area here and a bright area here, and this whole area is just a little brighter than it should be. And if you were to look at the OCT in those areas, you would see the outer retina was damaged or missing. And that's where you get so it's a window defect. So there's decreased absorption of the reflected autofluorescence. So when you look at a hyperautofluorescence image, as far as I know, there's two things that cause it to hyperautofluoresce: the increased signal or decreased absorption of your autofluorescence. And then the same is true of hypoautofluorescence. There's two main things. It's either decreased signal or blockage. So here's a patient with dry macular degeneration, geographic atrophy. And as we teach it, you'll see that these are considered low risk of progression. They're dark because the RPE cells are dead, but the edge isn't very bright. So this person I actually did see for years, and these didn't change very much. So decreased signal can be from dead RPE cells or from blockage. So every single autofluorescence you look at, you'll see the blood vessels block, so they're dark. So the blood vessels block, the nerve is an absence of autofluorescence, and then this patient has a couple spots of blood. So spots of blood will show up pretty nicely. I think this was a central vein occlusion patient. Spots of blood will show up nicely on autofluorescence. So either blockage or decreased signal or hypoautofluorescence, increased signal, decreased absorption, or window defect would be hyper. We look at a lot of autofluorescence images. This is a patient with chronic central serous retinopathy who came in. The retinas that looked very close to normal, but then when you got the autofluorescence, patient, it was totally asymptomatic, but when you look at the autofluorescence, there are these big gutter areas where this is dead RPE cells here, and these are kind of damaged, and there probably is a little bit of a window defect too. So you get everything in these pictures. Fluorescein angiography, we don't do as much as we used to. We just ran our practice numbers, and I get almost no fluorescein angiograms anymore. What we do is, but this is used to be a big deal, and it's still tested, and it's still important for diagnosis of several retinal diseases. You excite the fluorescein with a blue light, and it emits green. So in the old systems, which I don't think any of you will ever see, we used to just take a camera and flash a blue light and put in a green filter. With the SLOs, you have which is the scanning laser ophthalmoscopes, you have an excitatory laser, which is 488. So there's no blue filter, it's a blue laser. And then there's a barrier filter, which is 500 nanometers on the SLO. So what you do is you're barriering out the wavelength you emitted. So all you're seeing, you're not seeing any reflected light, you're only seeing the fluorescence. So the early images should be dark. 80% of fluorescein is protein bound, the 20% is not protein bound, and that's what you visualize. And fluorescein should not pass through an intact blood retinal barrier. This is why we may not lose fluorescein angiography, because in OCT angiography doesn't help you assess the blood retinal barrier. It's just a static image, even though they're very pretty images. Whereas fluorescein can show you things like leakage. So I'm not sure fluorescein is going to go away. It might. And then we talk about the phases all the time. The phases, the 8 to 12 seconds to fill. So it takes a little while. The fill phase is 8 to 12 seconds. The arm to the eye time is variable. It's anywhere from 10 to 20 seconds where it's dark. Once it gets past 20, that's a little worrisome. So if your timer's right and it's more than 20 seconds, there could be some problem with the patient. But then the fluorescein hits the eye. Your fill takes a couple seconds. Prior to your blood vessels filling, in the retina, the choroid starts to fill. And then you get a transit phase in the fill, which is 10 to 15 seconds. And this includes your arterial phase, where only the arteries are full. And you have to really, your photographer has to be really quick to get the arterial phase. This is only a second or two, a couple seconds. Your AV phase, where the arteries are completely filled, the capillaries are starting to fill, and the laminar veins are starting to fill laminar. The laminar phase, where the veins start to fill, these overlap. We'll try to clarify this. I don't think this is something that would be tested, but we do talk about it a lot in imaging conference. So there's the arterial phase, the AV phase, and the laminar phase, and then you get your peak phase, which is about a minute after the dye injection when you want to get a really nice picture. Recirculation over the next couple minutes, and then the late phase is when the fluorescein's mostly out of the blood vessels, and what you're seeing is fluorescein that's either recirculated or is leaked and stained things. So your sclera stains, your Bruch membrane stains, and your choroid stains. And then your large choroidal vessels darken as the dye leaves the body. So you'll see your choroidal vessels, through an area of geographic atrophy look dark. So those are your phases. And we'll go over that in conference. And then again, there's hypofluorescence. So this is different from hypo-autofluorescence. It can get a little confusing. There's two causes of hypofluorescence: a vascular filling defect. So if you look at this here, this is an area of non-perfusion. In a patient, I think this patient actually had Coates disease, although it looks a lot like sickle retinopathy. So I believe this was a Coates patient. So here's non-perfusion, and then also you get blockage from either fibrosis, pigment, or blood, and this was an area of blood. So your two hypofluorescence, when we look at an image, are going to be non-perfusion or blockage. And then hyperfluorescence, and this is something we do talk about all the time, and you will be tested on at the boards. There's 5 causes of hyperfluorescence, and it can get a little confusing on a couple of them. Leakage is when there's a gradual increase in fluorescence. If we show you one image, if you look at this image in conference, you can't say, oh, there's an area of leakage, because you're not seeing an increase in fluorescence. You have to look at multiple images. And leakage is from a breakdown in the blood retinal barrier, and the borders blur. So here you see this border, you look at it early, it's there, and then you look at it late, and it's here, so it's blurred out. So your borders are blurry, so this is leaking. Staining is when fluorescein enters a solid tissue. So the fluorescein, as the images progress in time, there's more fluorescein gradually entering tissues. If your borders stay sharp and it's increasing fluorescence, it could be staining or pooling. And the difference is staining is a solid tissue and pooling is a fluid space, like a PED or cirrus. Both of these have sharp borders. And examples of staining you see all the time are drusen stain, the scar can stain, the optic nerve can stain, and those will all have sharp borders. Examples of pooling are a PED or a serous retinal detachment, like you would see in someone with central serous retinopathy. So leakage is when it blurs. Staining and pooling are both sharp borders with increasing fluorescence. Window defect's easy. That's just like the autofluorescence, where you're seeing the fluorescein through an RPE defect. It's not a retinal defect, but you haven't. The barrier to seeing fluorescein in the eye is the RPE. So when there's RPE missing, you see fluorescein in the choroid that you wouldn't otherwise see. And then the weird thing about today's images, and this is not true when I was younger, is you also do see autofluorescence in your fluoresceins because the images are so high resolution. So anything you see on autofluorescence, you'll see on the fluorescein angiogram. And we'll talk about that more in conference. It gets a little confusing because some of it has to do with your signal. When your fluorescein's very bright, you really don't see much in the way of autofluorescence. So at your peak phase, you're not going to see autofluorescence, but early in the angiogram, you'll see autofluorescence the first couple seconds, and then very late, sometimes you'll see things that are autofluorescing. The rest of the time, it's swamped out by the fluorescein. There's a whole bunch of adverse events. If you're doing fluorescein angiograms, I think you legally have to have a crash cart because people can crash. It's not very common. They do get yellow. Your photographers usually tell people this. Yellow skin, orange urine, not to worry about that. Nausea, especially young patients. I just did a fluorescein on I think it was a 17-year-old. It wasn't too bad. If you do a fluorescein on a 10-year-old, though, hand them the wastebasket and leave the room because they're going to start vomiting within about 20 seconds. Bradycardia, extravasations, not really a big deal. And avoid during pregnancy just because it goes into breast milk. Next thing is indocyanine green angiography. This is 98% protein bound. So remember, fluorescein was 80% protein bound. Indocyanine green is 98% protein bound. So the 2% that's not protein bound is visible. And ICG fluoresces at a much lower efficacy than fluorescein. It's only 4%, and molecule of ICG is much less fluorescent. So prior to the SLOs, the ICG images were terrible. But now that we have SLOs, the ICG images are really nice. There's limited diffusion through the choroid capillaris because of all it being so bound up and so little of it. And the excitation is different. ICG is much more forgiving. The fluorescein angiogram is an unpleasant test. It's very bright. ICG is more in the infrared, near infrared wavelengths, or just infrared. So the patients aren't bothered by it at all. And then ICG is good for several things. RAP lesions, retinal angiomas proliferation, polypoidal choroidal vasculopathy, you really can only see in ICG. If you're going to treat central serous, it's nice to look at the leaky areas with ICG. And then with tumors and some of the multifocal choroiditis, you can really differentiate MUDES from AMPI, from multifocal choroiditis. They can look a lot different on ICG. And this is that same patient, I think, or maybe it's a different one, with central serous, and you can see the leakage. So the things where ICG gives you a difference over fluorescein is the wavelength is different, so you can see through the RPE, whereas fluorescein cannot see through the RPE. And it's protein bound, so the choriocapillaris leakage is, you can see differentiations in the choriocapillaris leakage. So those are your two big differences between ICG and fluorescein. This is a patient with polypoidal choroidal vasculopathy. This is a fluorescein angiogram on top. You see this is an example of pooling into a PED over here. This is an early, this is a late, and you can see something looking a little funny over here, but not much. And then here's the same patient with an ICG, and you can see this area of polypoidal choroidal vasculopathy right there with the vascular network and the terminating polyps. So you can see it's a much different image. And the treatments can be a little different. This is a cool, see if this is a GIF I made. Sometimes you can see a pulsating polyp. You see that right there? It's really cool. So this is an ICG of a patient with polypoidal choroidal vasculopathy. You can see a pulsating polyp. I think it's the last patient. In ICG, the mild adverse events, there are contraindications. It's interesting. The package insert says it contains iodine, used with caution with people with an allergy to iodine or shellfish. But the BSC book lists all this other stuff, anaphylactic deaths in people with cardiac catheterization. You know, there's penicillin, sulfa, renal disease, liver disease, metformin. I have to say, although that's not something we usually check, but we do avoid it with iodine and shellfish, but I don't know that that's even necessary. Some people say that you can do it. Honestly, with like I said before, with the OCTs and the other imaging we have, the angiograms are getting less and less necessary. And then OCT is a big thing. Resolution 5 to 10 microns. The high reflectivity is mostly mitochondria, RP, and nerve fiber layers, and lower reflectivity, vitreous and fluid, and the transparent tissues. The nuclei are very low reflectivity. When you look at the OCT, you should think about your retina. So the ganglion cells and the nerve fiber layer, interlinear nerve fiber layer ganglion cells are up here, and then the inner plexiform layers here, and then you get your nuclei, outer plexiform. It stratifies very much like the histopathology slide we showed you earlier. So this is the layers of the retina on the OCT, and we're going to talk about this over and over, but you really need to learn it. It's a lot to learn, and it's hard to remember in the moment when we're at conference. The interlining membranes on the surface, you can't really see it. It's only 10 microns thick. The nerve fiber layer is this bright line here, which you can assess, and it's important to get a feel for nerve fiber layer because you'll see people where it's absent, and not necessarily with glaucoma. Sometimes it's just absent by the macula for other reasons. Ganglion cells, you'll see the ganglion cell layer is not as dark as the other nuclear layers. It's a little brighter in reflection. Then you get your inner plexiform, inner nuclear, outer plexiform, outer nuclear. And then you get into these other layers, which we'll talk about over and over again. These layers are very important for vision, and they give you a good idea of the patients. You get better and better at guessing vision based on the status of the outer retina. This is the external limiting membrane here, and then you get this myoid zone, which is dark, and then the ellipsoid zone is the next bright layer. So you got external limiting membrane, ellipsoid zone, and then the outer photoreceptor segments are here. And Scott pointed out in conference the other day, that's why you get this little bulge, because there's so many cones in the middle that they're all trying to squish in there to help you see better. So your outer segment photoreceptors are there, and then your interdigitation zone, or as I was saying, the phagosome zone, is the first bright line, and the second bright line is the mitochondria, the RPE. So these 4 layers, which you can see a lot of times on a high resolution scan, it's important to know those: external limiting membrane, ellipsoid, interdigitation, and the RPE. OCT angiography has to do with eliminating non-changing signal. So what you do is if you imagine somebody running through a room and you keep taking a picture and then you subtracted out the background, you'd see the person moving because the background would stay the same. So you're taking repeat images and you're subtracting out anything that's stable and looking for moving things, which are in the retina, the only things that move are blood cells. Nothing else moves. So this is an example of a fluorescein angiogram with an OCT angiogram, and you can see the vessels way better on the OCT angiogram. It's still a little bit expensive, and it's still it still has artifacts, and it's still kind of a narrow window. But I think within the next couple of years, they'll get cheaper and we'll get better images. And then last thing I want to cover is B-scan, and then we'll get to images. We're trying to keep the lectures about 45 minutes, and I think I'm going to hit it right on the nose because we did start 5 minutes late. B-scan ultrasonography is important. Anytime there's a poor view of the posterior pole, including anterior segment and posterior segment opacities. For masses, you have to get a B-scan to measure the mass, and then if you're looking for retinal detachment, disc drusen can be very helpful. And actually I have another case today where the B-scan is helpful in looking for a foreign body. So if we have somebody with a vitreous hemorrhage and you need to see if they have a detachment, and we pull it out all the time. This is a patient with a tumor, and you can see the melanoma here, and then the B-scan shows the typical low reflectivity of a tumor. It's 2009. Probe positions, no one ever taught me this. So anyway, I'll teach you. You always keep the probe pointed up. So there's a little white mark on the probe when you're doing a B-scan, and the probe should either be pointed up, or if you can't point it up, it needs to point toward the nose. So the ones on top always point toward the nose, and then every other probe points up as you're going up around the side of the eye. Parallel to the limbus gives you the transverse cuts, which you typically get a transverse and a longitudinal cut. So you go parallel to the limbus, and then you go perpendicular to the limbus to get your two images over a lesion. And then axial is when your probes, if you're doing a B-scan, to get better resolution, you want to avoid the lens and all the junk in the front of the eye. So sometimes I even put the probe right on the person's eye, although not this eye. This is a pretty nasty looking eye. But I'll actually put a drop in and probe right on the eye to get a better image. But you can go through the lid. But if you're avoiding the front of the eye, you get better images. But for an axial scan, you go right through the center of the cornea, and you transect the optic nerve. So a horizontal axial goes through the macula and the optic nerve. A vertical axial goes through the optic nerve this way. So you got three cuts: transverse, longitudinal, axial. This is a patient with a vitreous hemorrhage and these hyperreflective things. And that's the same patient. And then here's a movie, and you have to decide, is that a retinal detachment? So you see this, here's something that looks like maybe blood, and then here's this other thing back there that looks a lot like a retinal detachment. So you can, I'm not looking at your images, so you can raise your hand to yourself if you think that's a retinal detachment. Okay, and then I'll show you another image, because it's a big deal. You either take the person to surgery. This is another one, and you have to decide if that's a retinal detachment. And then here's the movie of the eye moving. So you'll notice these look different. This is a retinal detachment. So this one, you see how it's hyper-reflective the entire way. So you can't find a gap. The person's, unless you see the tear, which I think might be over here. But you can see it's super bright all the way across, almost as reflective as sclera. And it kind of wiggles in a really sort of scary way. That's why, my post-retinal detachment patients, I have them not read. They're not allowed to do any recreational reading for a week after my surgeries because of this, because of that. Yeah, I should show them this video. Actually, maybe I'll do that. So that's a retinal detachment. When you look at the other one, it looks a lot like a retinal detachment, but it's just not. And the reason is that there's breaks. So this one clearly, it's just not as bright. You see how when you follow it, you look at this one, okay, that could be a retinal detachment, but there's nothing there and there's nothing there. And then you go a little more and well, that looks like a retinal attachment, but then there's a gap there, there's a gap there, a gap there, and a gap there. So it's just not a retinal, even though it's a stained posterior hyaloid, It's not a retinal attachment. And the 2 layers are just layers in the vitreous. This one I thought was one of the more, I tricked other retina specialists with this one. Because this look, you think, oh, there's a PVD, so that's a detachment. But this is actually just vitreoschisis. I did take this patient to surgery because this didn't clear for a while, and I can tell you there definitely was not a retinal detachment. The other thing is if you do go into retina, don't trust your B scans. So as you're doing it, even though you do them yourself, and I can tell you for teaching purposes, 99.9% that's not a detachment, you still go slow because you can be wrong. I had one, when I had my first year in practice, first or second year in practice, I had a patient who came in with a shadow that sounded exactly like a retinal detachment. In a B scan, it showed nothing. I mean, it didn't look like this and it didn't look like this. And when I took him to surgery, they had a giant retinal tear, which had folded on itself. And that was in the early days of perfluorine. Thank God I had some perfluorine. Now it's easy, you just unload it with perfluorine. But I had some squandered away. So those are B scans. So you got to get used to doing your B scans and your other tests. So in review, talk to you, anatomy is a lot to cover. Neurosensory retina, RP, Bruch's membrane, choroid. Try to remember, like you got to know the fovea is all cones, and you've got to know your RPs, the blood retinal barrier, and you've got to know the center layer of Bruch's membrane is the elastic layer, and the choroid is extremely high blood flow, and the choroid is permeable to fluid. And then your autofluorescence, we'll be talking about these in conference. So we'll refresh your memory every month on the how to look at tests and read tests. But I wanted to get this review in before we started doing cases.